During initial 48 hours, then base deficit more than 4 millimil, and then calcium less than 2. So calcium is important. Then fluid sequestration, and then all this one. Then we are going to how you are going to manage this case. So usually in homeless cases, it is going to be like the presentation is going to be like that, but uh, the pain, it could be a chronic case too, so don't always think of acute because a homeless patient could have this thing going on for too long. So don't just always think of acute. NPO, hydration, analgesics, and early enteral nutrition. Antibiotics are not indicated for initial diagnosis. Along with spontaneously, usually no surgical treatment. Cholecystectomy can be done after the treatment. ERCP surgical management. So local complication is acute fluid collection or any pancreatic fluid collection, abscess, infection, pancreatic ascites, diabetes mellitus, ARDS, sepsis, or multiple organ failure, coagulation, DIC, or hypocalcemia. Mm. Chronic, like chronic is basically when they are having thing going on for too long. So this is basically an indication of the surgery. Splenic trauma, because may have occur signs. It's this sign is important and it's very common in the blunt trauma. So this one, okay? And in that case, we do FAST and CT scan. In stable patient, bed rest and then hematocrit level, close monitoring in hemostatic level and splenic artery immobilization. In operation, we will go for the removal of that one. Then comes the breast one. Fibroadenoma is very, very important. Like fibroadenoma as compared to lipoma. Okay. So mainly the diagnosis is core or excisional biopsy, ultrasound, FNA alone cannot be differential diagnosis. So first of all, if there is anything going on, like if there is a mass fibroadenoma, then go send for ultrasound. But if a patient is 44 or 45 years or above that, where we start the breast screening, mammogram, and then going for ultrasound. And then if needed, they do excisional biopsy. Okay. So conservative treatment is doing the excisional biopsy or watch and wait and see if this is getting bigger or smaller or how is it working. Then breast cancer, obstruction, abscess, fat necrosis. Okay. In this one is more important, like NACOSCI point of view, because if a patient can present with a BRCA1 positive, how you're going to deal with that patient, counseling and all that. In MCCQE1, I wouldn't think that they would ask something like this. In usually in this one, they like in MCCQE1, they do like to ask about the diagnosis. Like they do like to ask like when are you going to do mammogram? Okay, in which case you are going to do ultrasound, in which case you are going to do excisional biopsy. This is what they do like to ask in NCQE1. But in NACOSCI, they do ask if the BRCA1 positive, the patient asking you if I am going to be a cancerous or not. So a lot of people, I let me give you an answer to that one. A lot of people do come with a family history and their BRCA1 is positive, but in their later life they cannot or they might not have a breast cancer. But in many cases you have to let them know this is not 100% that you might have a cancer. BRCA1 is basically a family genetic, that because your family was having cancer and you came out positive, it could be a alarming sign for you and it couldn't be. So based on this one we cannot say that you might have a breast cancer or ovarian cancer. But at the same time, it's best if you do one yearly screening for the breast or mammogram consecutively. Okay, so I hope that makes sense. So this is basically a NAC OSCE question, not a QE1 question. But genetic screening, consider testing for BRCA1 if young patient, bilateral breast cancer, family history of breast cancer, or family history of male breast cancer, patient diagnosed with breast cancer and ovarian cancer. Okay. And then the screening is important. And then post-operative follow-up, assessment and the physical examination every 3 to 6 months. So when are you going to do, like, let's suppose he did whatever mammogram, he did vaccine biopsy, he did whatever mastectomy. Now, how are you going to follow up? So every 3 to 6 months for every 3 years, then every 6 to 12 months for every 2 years, because this is a family medicine thing you are going to do, and then annually thereafter. Consider the mammogram every 6 to 12 month can reduce to annual once stable and no routine imaging unless the clinically indicated. And women who receive tamoxifen may have the regular gynecological follow-up. Okay. Yeah. So I think that's about it from the general surgery. Um, if you have time, you can read more and then go through everything. Like in this one, in the pediatric surgery, usually you don't need to do the treatment, but the just like hydrocele, you need to know the physical examination like transammination test, then checking for the palpating and checking for that one. Um, then pyloric stenosis, projectile non-bilous vomiting, vomiting every 3 to 6 minutes after the feeding. And in this case, we're checking for the electrolytes for hypochloremic dehydration and doing the ultrasound. And very important, how does the ultrasound look like for the pyloric stenosis? Then coming to the diaphragmatic hernia, the abdominal X-ray is important. Go and check how does the abdominal X-ray look like. Meckel's diverticulum, the presentation is important. How does it present? And then Meckel scan, basically abdominal X-ray, there's tenderness and then distension, so stabilization. Gastrus cases as compared to the amphelocele, how does it look? How does it present? What is the main main treatment or main approach to this case? It's basically NG tube decompression. And we start with the surgery right away, although, but NG tube decompression, you are the family physician or whatever you are. So you have to start with NG tube decompression. So although we start with ultrasound and everything, but when the patient presents with gastrus cases, you need to know how does it look like. The diagnosis is important. And how does it look from the Google? Just go and see how does it look like. Intussusception, abdominal exam to palpate for the masses, and you are going to do the abdominal X-ray. Signs of bowel obstruction in the kids. So that's about it. So we did the general surgery. Let me quickly go to, we do have some time, so let me go quickly go to gastrointestinal if we can. This. Yes. Mm, Let me just tell you what you need to do from gastrointestinal, just an idea. Diarrhea is very, very important, especially the acute diarrhea in kids and in the older people too. Okay. Okay, so we are starting the gastroenterology. Let me come through the topics first. What are the topics here? Okay, so if you go here, you already did all of this one. The GERD is important. Okay, gastroesophageal reflux disease. Then dysphagia. What are the complications and how does it present? And sorry, what are the differential diagnoses, not complications? Then dyspepsia, peptic ulcer, and especially the H. pylori peptic ulcer, the complications of H. pylori peptic ulcer. And I think we already acute diarrhea, traveler's diarrhea. Celiac disease you can do because with the diarrhea you mainly covered the celiac disease, and you know how you are going to deal with that case is basically gastroenterologist. And we already discussed about inflammatory bowel disease. Then upper GI bleed and lower GI bleed, the mainly the emergency presentation of both of them. Hepatitis B, their whatever the test is. Hemochromatosis, in which level of iron when you think of hemochromatosis? Yeah. And then we already discussed this one. Okay, so let me quickly go. Mm. Just please don't forget to read sidebars. I'm not reading it, but you have to read everything from the sidebars. As you can see, there are certain very, very important things. IBD is a common cause of bloody diarrhea, but can be diagnosed only if mimickers are excluded, such as infection, ischemia, medication induced. Okay. So sometimes they just give you the straight lines from Toronto Note sidebars. Starting with the GERD, basically gastroesophageal reflux disorder, a condition where the reflux of the gastric is important. Contents cause the troublesome symptoms. Then the GERD sign is basically coming from non-esophageal and esophageal, respiratory, non-respiratory. If it's a respiratory, causing chronic cough, wheezing, aspiration, pneumonia. So it can present as the patient is having a chronic cough. So don't forget about GERD. Don't think of as like keep thinking of asthma, COPD, and all that, but don't forget about GERD as well. Sore throat, hoarseness, and dental erosion. Heartburn is in esophageal. The symptoms are heartburn, acid regurgitation, chest pain, dysphagia, and odynophagia. In this one, usually a clinical diagnosis, so don't write any test. It is a clinical diagnosis. This is the word that they are looking for, like they're asking you for the investigation. So it's a clinical diagnosis, no investigation. So then anti-secretory agents such as PPI is not required for GERD diagnosis. Absolute indication heartburn accompanied by the red flags. So bleeding, weight loss, dysphagia. So in those ones you have to do gastroscopy to think if there is an underlying cancer or anything going on. Reflux symptoms, history of the esophageal strictures, high risk of barium esophagus. Sorry. Okay, so repeated endoscopy after 6 to 8 hours of the PPI therapy. This is important. They will ask you with this one. If they have given PPI, when are you going to do the test and which test? Endoscopy after 6 to 8 hours. Then endoscopy manometry, so 24-hour pH monitoring. So usually we give for PPIs and start with the treatment, pantoprazole, rabiprazole, whatever it is. And how long you have to give? 8 week trial. So although in some cases you don't need to memorize for how long, which one, whatever it is, but in some cases like otitis media, you need to remember for how long you need to give the antibiotics and which antibiotics. For syphilis, you need to remember which penicillin. Is it a benzathine penicillin? Is it IM? Is it whatever it is? So you need to remember the name of the penicillin. In this one, you need to remember 8 week trial of PPIs. Okay, discontinuation of PPI after 8 week in in recovered patients without the Barrett esophagus or erosive esophagitis, and then we go for antacids or whatever it is. So the main lines are these ones: the 8 week PPIs, giving then chronic cough, uh, wheezing. So these are the signs, okay? And then usually, like especially the Barrett esophagus, eclasia, just see the pictures. How does they look like? In this one is basically acid suppression PPI usually we give. This one You can see from dysphagia just this table. Approach to dysphagia is an oropharynx or is an esophageal. It's a neurological, muscular, or the structural. Then in this one is solid fluid and the liquids. This one is important. Why? Because of the Nagoski. And in when it comes to Nagoski, sometimes they do ask you in QE1 too. So just knowing if it is just a solid one, what could be the diagnosis? If it's solid and fluid, what could be the diagnosis? That's it. And then eclasia, how does it look like? And when the spasm, how does it look like in the barium X-ray? Okay, so it's important. You need to know the like you can differentiate between eclasia from the spasm. Although it's a pneumatic dilation, whatever the complete treatment is, but you need to know the difference between the esophageal spasm and then eclasia. So eclasia, we do a chest X-ray, no air in the stomach, dilated esophagus, barium studies, esophagus terminates in the narrowing. So there is a bird beak appearance, then endoscopy and manometry. For diffuse esophaspasm, is basically barium X-ray and there is corkscrew pattern, manometry and then endoscopy. In this one, we do pneumatic dilation to open it up, and then this one is reassurance that symptoms are not due to cardiac pain. Usually people think that they are having heart attack or MI. Then we were talking about dyspepsia. In this one, the investigation is important. Consider blood tests like CBC, liver enzymes, and calcium, and H. pylori serology and ultrasound. Usually, the most common is functional, as you can see. Yeah. Then comes to the peptic ulcer disease, one of the most important one. Uh, and then it can lead toward the cancer. So that's why increased risk of cancer, death from the ulcer, and it can lead to increased risk of cancer, impaired healing and all that. So then it's basically the clinical features, dyspepsia with the complications, bleeding 10%, obstruction 2%, and inflammation 2%. Then the duodenal one is basically with the epigastric pain, burning, develops 1 to 3 hours after the meal. And I think the one that is the gastric one that just develops before the meal. It's just that something is different between the duodenal with the gastric ulcer. And when they give you in the diagnosis, they do like to expect you to write down if it's a duodenal one or it's a gastric one. Okay. Relieved by heating and antacids and interrupts with the sleep periodicity. More atypical symptoms are biopsies needed to exclude the malignancy. Endoscopy is most accurate one, then upper GI bleed, and usually we don't do upper GI series and H. pylori testing and all that. Testing is basically treatment is basically giving that treatment of H. pylori, the triple regime and all that. So stop antacids if possible, start PPIs, heal more ulcers, and often medication, discontinue cigarette smoking, no diet modification required, but some patients may have fever symptoms if they avoid caffeine, alcohol, and spices. Approach to PUD, stop antacids, acid, and then H. pylori dedication, quit smoking. So in this case, how you are going to read it, like I'm reading it like as if it. So when you are reading peptic ulcer disease, just read a little bit of diagnosis, like clinical features, signs and symptoms. So what you need to know in this one, what are the main investigation that you need to do, and then what are the treatment. Okay, as a family physician, as an emergency physician, that's it. And then if you feel like this is a surgery and it's very important and it could be asked, then you can just read the surgery name. Discontinue cigarette smoking. That's one of the important. Management of the bleeding. If it's a bleeding one, now it's present as an upper GI bleed. In that one, gastroscopy to explore the upper GI bleed, IV pantoprazole, establish the risk of the rebleeding and continuous bleeding. And clinical risk factors is increase age more than 60, bleeding diastasis, history of peptic ulcer disease, comorbid disease, hemodynamic unstable. So you can see it can present suspected bleeding peptic ulcer. You are going to start with airway, breathing, circulation, assess the vitals, BP, heart rate, orthostatic if patient is going in shock. So this is just the main protocol. So wherever, whatever the case is, don't think of yourself as a gastroenterologist or anything. Think of yourself as an emergency physician or family physician. So your main approach is airway, breathing, circulation, thinking of what you can do at that point, and then going for that. CBC, electrolytes, BUN, creatinine, INR, blood type, whatever it is. Then resuscitate crystalloid and the blood products if indicated. Then consider NG placement. If they have given in the MCQs or in the exam or whatever, if they give you that they have done the basic protocol, now you can start with NG placement. Don't just think of it. Okay. So if they give you an upper GI bleed, your first thing is airway, breathing, circulation, or whatever, circulation, breathe, airway, breathing, or vitals. Okay. Then resuscitate, crystalloid. You have to go one by one. Then NG placement. If this says in the MCQs that this is already been done, then go for NG placement. If they says NG placement has been done, still there is whatever going on, then IV pantoprazole, then erythromycin before endoscopy, then it's endoscopy, active bleeding. Then if we are doing endoscopy and there is active bleeding, then what you are going to do is a high risk. They give you an example like hemostasis, clips, and all those ones. Then, if it's a low risk one, the flat pigmented spot or the clean base, then the low base, no hemostasis necessary, continue oral PPI is decreased need for the in-hospital monitoring, and then you can discharge the patient. In high risk, hemostasis, clip, thermal coagulation, epinephrine injection, continue IV, monitor for rebleeding. If adherent clot, consider removal, and then post appendectomy, endoscopy. What are you going to do is resume the clear fluid 6 hours and test for H. pylori. Then most likely causes are NSAIDs, antiplatelet, or if rebleeding, repeat the endoscopy. So you need to see in the MCQs at which level they are and at what level they are asking. So don't just start assuming, oh, I think now they have given too much to me. I feel like airway breathing is done. So don't assume, think of what is done is written there. Then this one here, just reduce position. Then comes to the diarrhea. Diarrhea is one of the most common presentation in emergency medicine, even in family medicine too. But in family medicine, the case is little bit stable. But in emergency, it's more like electrolytes disturbance and all this later on complications. So you can see here, acute diarrhea is basically passage of more than 3 fluids. So that one. Then what is the risk factors? The food, medication, and high risk sexual activity, infectious outbreak or the outpatient exposures, especially in pediatrics, rotavirus is very common. So in that one, useful questions in the acute area. So all of this one, travel, sexual activity, if it's a fecal oral exposure, outpatient, seed food, extra intestinal, family history, antibiotics, diet, steatoria, or weight loss, immunosuppression laxatives. How you are going to approach. So the most common cause of diarrhea is basically infectious. In most cases, acute diarrhea in illness is viral or self-limited and lasts less than 3 days. Investigations are costly and necessary only in the certain circumstances. Therefore, evaluation of acute diarrhea involves identifying the characteristics of the patient or illness. So it means you have to find out. So that's why it's important to ask all those questions. So you have to find out if it's a viral or if it's self-limiting, if it's an antibiotic he's taking, and then that is causing it. So stopping those ones. Checking for dehydration status is very important. So don't forget about dehydration status. Volume status like appearance, level of alertness. So they can ask you in physical signs, what are you checking for? So, or what would you like to start with? How you're going to approach it. So it does not mean you have to write on this one. You have to write on here with physical examination by looking at the patient, the checking for the volume, the pulse, these ones, orthostatic, BP, mucous membrane, skin turgor, capillary refill, or maybe they can directly ask you what are the signs of or what are the things that you look to assess for dehydration. Abdominal exam check for the pain, guarding, and peritoneal signs. Here they give you a little bit of what it could be the inflammatory and what could be the non-inflammatory one. The symptoms are important. The inflammatory is mainly the bloody, not always, small volume, high frequency, often lower abdominal cramping, and there is feeling of tenesmus. And non-inflammatory is watery, little, no blood, large volume, and then there is cramping and shock. So in the inflammatory one, there is a lower abdominal cramping. In non-inflammatory is an upper abdominal cramping. Okay. The investigation is obviously we always start with ova and parasite, culture and sensitivity of the stool more than anything else, checking for the stool for ova and parasite and culture and sensitivity. Then flexible sigmoidoscopy and any toxin or whatever you think. Starting with fluids and like conservative management, starting with resuscitation, fluid and electrolyte placement. Antidiarrheal like lepromide is very, very common here in Canada. Anti like motility agents, side effects is cramps, toxic megacolon, those ones. Antibiotics rarely indicated. So it's very rarely used antibiotics. Causes of acute bloody diarrhea is basically Campylobacter amyloid, all this one. Initial assessment, any of that one. So checking for this one. So when are you going to report this one to public health? If there is a fever, bloody, severe abdominal pain, profuse diarrhea, hospitalized, age more than 65, immunocompromised, diarrhea, exposure of suspicious food or untreated water. Like, a lot of patients are coming from one area, be like, oh, I'm having this, whatever I drink, water or eat or something. So it happened to me. Sexual contact, men who have sex with men. So investigations, all we already discussed the stool culture and sensitivity, stool over and parasite. Treatment is the resuscitation part. Okay. Mainly knowing about inflammatory from non-inflammatory, investigation, and how you're going to treat. Simple. And then you can read this one. This one is, I know it's kind of stupid to remember this one table, but you need to remember this one on fingertips. They can ask the pathogen. Okay. This pathogen is important based on the clinical features. It's kind of hard, so you have to memorize it. So how much incubation period, the bloody one, non-bloody one, depending on the clinical features, and then knowing the pathogen. Because what kind of pathogen can spread from which of the source or from which kind of presentation it is. So you need to know. It's basically they ask in MCQs. Okay, so everything. This Bacillus cereus, Campylobacteria, the Bacillus cereus A and B both, Campylobacter, Clostridium difficile, Clostridium perfringens, E. coli, enterogenic E. coli, and then Salmonella, non-typhoidal Salmonella, then Staphylococcus vibrio, Yersinia, Cryptosporidum, Entamoeba histolytica, and Giardia. So you need to know just the names, how the source of spread, and their clinical features. And then mainly the virus is basically norovirus and rotavirus. Traveler diarrhea. So most common illness to affect the travelers. The main treatment is rehydration. Simple. And mainly it's basically E. coli is the most common one. Okay. So if you read this one, you will be able to memorize this one. Then comes the prevention. Prevention is important because you as a family physician, they can ask you. So poor hygienic practices, bismuth salicylate, antibiotic prophylaxis not recommended. Increased risk of infection with the resistant organism, high risk of groups. Then Ducorol is basically oral vaccine that offers the protection against the Vibrio cholera. So usually, we only give it to those people who are about to travel to those areas where there is Vibrio cholera. And you need to memorize which are those countries where there is common Vibrio cholera, because they can ask you a question. It can be covered in epidemiology. A patient is going to South Africa. You are a family physician. What are the vaccines you would give to that patient? So you need to know what could be the outbreak in South Africa. So on the base of that you would offer this patient, okay, you can take this malarial one, you can take this whatever, it could be on that one. So you need to remember this one. Okay, this is very important. The two doses must be taken 2 weeks. So this is how the doses can be taken, public agency and all that. Um, Let me do a little bit more and then we'll take the break. So here, I'm not sure. But you can read this one too, because I saw 2, 3 MCQs coming from this one, where the vitamin B12 is absorbed, where the vitamin A is absorbed. So just remember this one. Where is the absorption of these ones? I mean, more than whatever the other thing is, they usually like to ask whatever the absorption is, especially the main common ones. What are the main common one? Vitamin B12, iron, vitamin A, D, um, folic acid, yeah, especially at least these ones. Okay. And then this is a celiac disease. Basically, treatment is under etiology. So these are the tests. What are those ones? TTG, IgA antibody, 72-hour fluid collection checking for the weight and fat content, then serum carotene level. These ones. Okay. So just read the investigation for the celiac disease. And then we'll continue from here. So just remember the celiac one, the investigations, and the treatment is basically dietary counseling. Yeah. And whenever you are reading something, especially like diarrhea, celiac disease, IBD, remember, don't forget to see a quick look on their complications as well. Just see a quick look. You don't have to memorize, you don't have to see, just take a quick look so you have an idea about what can be the complications. As you can see, celiac disease can cause this kind of thing. And you can, as I said, iron, calcium, folic acid absorbed in the proximal small bowel. So you can see this one, this line is important. And more common, the vitamin B12 absorbed in the distal one. Okay. So this is the line I was talking about. So which vitamin is absorbed from where? So you can see you don't have to go into proximal or the one ascending one or whatever. You just need to see like this one is basically iron, calcium, and folic is absorbed from the proximal small bowel, and then what is absorbed from the large bowel. Okay. And then we'll start from here from tomorrow.